Hello, students. Let's talk about a few things. I'm going to talk to you about postpartum infections, ATP today, some bleeding disorders specifically, and then also we'll be talking about hemorrhagic shock. Okay, so let's start with postpartum infections. So the number one preventative measure for postpartum infections, of course, is not only nurses and healthcare provider providing good hand hygiene, right? But also teaching our family members, our clients about hand hygiene and good hygiene practices. So sometimes we'll have a client that develops a fever during the postpartum period. Usually 24 hours after she's been there. So if she delivered her baby on a Saturday, usually Sunday evening, if she begins at that point to start developing a temperature greater than 100.4, and it stays there for 2 days in a row, she's got this fever. Usually that's a concern that we have an evolving infection. Endometritis is the most common. I've had clients be discharged home, and then within 4 or 5 days after discharge, they call the office and say they have a fever. And the first thing that comes to my mind is endometritis. So usually endometritis could be easily caused by just having a cesarean section or inability to eradicate chorioamnionitis. Endometritis is an infection of the inner lining, endometrial lining of the uterus. And that's why it's called endometritis. Okay, it's not endometriosis, it's endometritis. Okay. When we do cesarean sections, like other surgeries, we use prophylactic antibiotics before the cesarean section. So as we're making an incision to do the section, we have Ancef infusing, or the drug of choice of the obstetrician. Okay, and this helps reduce the incidence of endometritis. Some other presenting things are she doesn't feel very well, she has a fever, she might have a rash on her chest. That's something that I've noticed. Doesn't mention that in your text, but sometimes an upper torso rash is an indication of endometritis. So we have to admit her and treat her. Surgical incisions can get infected. We do our continual assessment of incision sites, make sure there's no edema, no drainage of any sort, make sure it's approximated, and that we use precautions, hand washing when we do dressing changes if necessary. Okay, so we also teach our clients about surgical incisions, perineal lacerations, hygiene, using a peri bottle, just patting the area after cleansing, keeping her peri pad clean. Urinary tract infections, you know that during pregnancy, a client is predisposed to urinary tract infections because there's a lot of stasis of urine in the kidney as well as the ureter. The ureter is actually dilated, so she's just kind of predisposed to infections. But postpartum, because of maybe the trauma of labor and delivery, vaginal delivery, and if she's not drinking enough medication, the hygiene practices. So either a full out urethral or renal infection, or just maybe bladder inflammation, which is called cystitis. So do you remember the signs and symptoms of a bladder or urinary tract infection? Okay, painful urination, dysuria. So if she says she's having pain when she urinates, ask her, does it hurt when she's starting, or does it hurt after she's finished? Because sometimes that lets us know the location. So if it hurts after she's finished, it's usually the bladder. If it's hurting as she is urinating, it's usually along the urethral tract. Okay, but we really use the same antibiotics either way. Okay, so we want her to flush out. A lot of times a woman can flush out a urinary tract infection by drinking extra water. So we do want to encourage her to do that. And then front to back washing the perineum. And then lastly, mastitis. Mastitis usually caused by a clogged milk duct. So we need to continue to keep the breast empty for a mother who's breastfeeding. Even if she develops an infection, she develops mastitis, we need her to continue to empty the breast. If it's too uncomfortable for breastfeeding, then pump it or express it by hand. You can feed the baby, or clients can feed the baby on the other side, but it's still safe to breastfeed the baby in an infected breast, because that mastitis is not in the milk, it's in the soft tissue. Okay, so usually what she's going to experience with mastitis is a fever, warmth and erythema on that particular breast, flu-like symptoms, aches and pains maybe, and we have to give her some analgesics, some ibuprofen, and some antibiotics. One of the best antibiotics for mastitis is dicloxacillin, because it's a penicillin specific to the breast. So it works very well. Warm compresses to that breast improves circulation and helps that to clear up. Frequent, make sure that breast is emptied frequently. Okay. We also treat to help prevent mastitis also is alternating feeding of a newborn, breastfeeding. Okay, begin with one side, empty it as much as possible, and if the newborn is still wanting to breastfeed, then finish up on the other side. Okay, and then a couple hours later, when you're feeding the baby again, you're going to start on that second side and continue until it's very soft and it's nearly empty, and then you can use the first breast again. So we want them to alternate and make sure they're emptying the breast. She needs a very supporting bra. Bras are not going to hinder or cause infections. It's good to support the breast because they're heavy and they need support to help prevent problems. So that's the postpartum infections. So keep track and explain to your client the importance of knowing if she has a fever. So make sure you're monitoring the temperature. Let your clients know when they go home if they develop a fever of 100.4 or greater that they need to contact us, so we can evaluate what could possibly be going on. Remember, we also promote nutrition during discharge, how important it is during recovery from a pregnancy, have good nutrition, fruits and vegetables, lots of fluids, rest periods, not to overwork herself. So rest periods throughout the day and good nutrition will treat a lot of disorders. So bleeding disorders. Now, we haven't talked about this too much. I haven't. There are a lot of different bleeding disorders, but particular to the postpartum period, we're talking about hemorrhaging, right? Postpartum mortality, usually from postpartum hemorrhage. So what are some things that we need to know about our clients to be prepared for postpartum? Von Willebrand disorder is a deficiency of factor VIII, clotting factor, okay? It's usually found in the wall of the blood vessels, okay? There are some people who don't have that factor, or they have a deficient number of von Willebrand. So what are some things we see in a client history who has von Willebrand? And usually they know it because women with von Willebrand tend to have longer periods. Not necessarily heavier periods, but they just extend longer. They're at least a week long. Okay, their gums bleed easily if their von Willebrand is active. Von Willebrand is one of those disorders that they have quiet periods and then or remissions and then exacerbations, just like a lot of other immune systems will happen. So von Willebrand is an autosomal dominant disease. Usually as far as blood work, you will see everything looks normal except the bleeding time is extended. So they're going to have longer periods. And then, of course, in the postpartum period, it's going to take, their loci will probably be longer. So we need to instruct them if necessary. There are different drugs we can use to treat that. And that's really beyond the level of this class. Okay, and then immune thrombocytopenia purpura. This is a immune system disorder. You can develop this as a child. This can be caused by trauma. This can be caused just by an acute onset. Viruses sometimes will cause it. So it's varied how you can acquire this. You can be born with it, obviously. I haven't had too many clients. It's kind of rare that have ITP, and sometimes during pregnancy it might rear up. And what's going on is that the immune system is developing antibodies against platelets. So the IgG, which is one of the major antibodies that our immune system has, develops antibodies against the platelets. Okay, so the platelets are destroyed, or they're not allowed to live as long. If the platelet level drops below, and usually what we see in platelet levels are very low. So if a client comes in pregnant and they have a history of ITP and they've been in remission, we'll certainly get a platelet level with our CBC, and we'll see where she is. If she's below 100,000, then yes, she's probably experienced an episode, but we're not going to do anything about it until it gets low. And then usually if it gets below 50, we will begin treating with a steroid drug. So we'll reduce the destruction of platelets. Just a low dose steroid, oral steroid, for these clients. Sometimes we'll see everything else, all the other lab values are normal other than the platelet level. We also might see an enlarged spleen. The spleen is what produces the IgG, so that's very active. And sometimes the resolve to this disorder is to actually remove the spleen. Okay, so you also might see liver enlargement in these clients. But usually, so if you have a client with a bleeding disorder like ITP or von Willebrand, these clients are not able to have any kind of spinal or epidural neuroaxial anesthesia, because we can't inject in around the spinal cord and cause bleeding. Okay, so we can't, it's contraindicated with these clients. Okay, so DIC, if you remember DIC, it's different. Okay, it's not autosomal, it's not an inherited thing, it's not an immune system thing, it's something triggers it. And of course, it's not particular to pregnancy. Something just triggers DIC, and there is a massive consumption of all the factors in the blood to clot the blood. Okay, so the labs that you'll see with DIC are low red blood cells because hemolysis is going on, low platelets, prolonged PT and PTT. You'll see fragments of red blood cells because of the hemolysis, and your INR is going to be elevated. your fibrinogen degradation is going to be elevated. Okay, so the inability of the blood to clot, bleeding time isn't really changed. But so once those factors are used up, and then mother or client begins to bleed out. So we have to make sure we have a second IV site dedicated to blood products and colloid type solutions. Okay, so those are the three differences in the three, and it can be very confusing. But just know that we need to know our client's history. We need to ask her if she has any bleeding disorders. And we need to ask her if they say they have von Willebrand disease. Well, tell me how long your periods usually are. Have you ever been treated for it before? Was it a problem with the previous pregnancy? So we just have to know those sorts of things to make our plans. Okay. So I have some other slides here. So what are you going to see with ITP? Initially, if the platelets are very low, the little small capillaries that are more superficial that we can see begin to be very prominent. And it's like a rash, a pinpoint area, and then a little wiggly line. It's a petechial rash. It's a sign of bleeding caused by lack of platelets, sorry. So it's a sign of liver disease. So if a client has liver disease, they're also going to have petechiae. Okay. Purpura is just the bluish discoloration from the bleeding that's occurring. Okay, so you'll see patches interlaced, red and purplish. Let's see. Significant bleeding if platelets drop below 20,000. Usually we don't let them drop that low. Okay. So the concern we have with this is that if mother's platelets are very low during the pregnancy, she's at risk for delivering a preterm baby, and the baby could have thrombocytopenia. Okay. And if the baby does not have adequate platelets, then we might see some intracranial bleeding or some abdominal bleeding. So we need to monitor, and that's why we need to treat during the pregnancy to prevent that from happening. Okay. It's individually, there's no standard dose. It's dependent on the provider and the client history and the platelet level. So as we think about bleeding disorders during pregnancy, we have to remember what our priority is for the postpartum period then. What is our priority? We have to stay very alert to bleeding, whether our client has ITP or von Willebrand or maybe factor II deficiency, some kind of bleeding disorder. We need to make sure we know what our priority is. We're not going to do a cardiac assessment or a detailed neuro assessment on our client before assessing the condition of the fundus. Okay, so the priority assessment postpartum based on Uber is the uterus. Okay, the first order. Okay, inspect the uterus. You can see it, right? You can see the fundus. Is it midline? Is it above the umbilicus? Where is it? It needs to be right around the umbilicus or a hair above, maybe one finger breadth above, but no more than that. Or is it deviated? So is it firm? Palpate it then. Is it firm or is it boggy? What do you do if it's boggy? We massage it. But we need to massage, but we also need to inspect the bladder. So B stands for the bladder. Palpate the bladder. Make sure it's not distended. Because a bladder that's distended, full of urine, doesn't allow that uterus to contract. So it doesn't do a whole lot of good to massage if the bladder's full. So if the patient can get up and go to the bathroom, great. If not, sit her on a bedpan. If she can't do that, then put a catheter in. We've got to get the bladder empty. And then you can go back to massaging and consider what other things that you can do. Medications, fluids, oxygen. You're always in the back of your mind, you're thinking hemorrhage. Okay. You're thinking, what do we need to do to prevent her from bleeding so much? Okay. So the next thing you're going to do when the bladder is empty, you're going to inspect the perineum. So E stands for episiotomy. Okay. So look at the perineum. Did she have an episiotomy? Look at the sutures. Are they intact? Does it look like anything's come apart? Do you see a tear anywhere? Okay. Any lacerations? And then lochia. How much lochia? And by this time, you've got more people in the room to help you. So somebody needs to be assigned the duty of weighing peripads, anything that has blood on it. Keep track of the weight because 1 gram of blood loss is the same thing as 1 milliliter. Okay, so we are keeping track so we know that how much she is bleeding. Okay, and we define hemorrhage then after a vaginal delivery as 500 mLs or more. Okay? And then lastly, once you've done all your interventions and she's stable, make sure you check the rectum for hemorrhoids and address those. All right, so Uber. Those are your priorities. Once you know your client is stable and the bleeding is not excessive, you've given her drugs, you've taken care of her, she's comfortable, she knows that she needs to void, then you could start over after washing your hands and replacing your gloves with a breast exam. Okay, and your breast exam, and you're also going to assess the mother newborn dyad. Are they bonding? Is that going on? How is your mother's emotional status? So that's part of your postpartum assessment, ongoing assessment. So what if you enter the room and you've been assigned a postpartum client? She delivered a macrosomic newborn 40 minutes ago. And you determine, you know what your priority is. If she delivered a large baby and vaginally 40 minutes ago, you know you need to check that uterine fundus out. So you're inspecting and you're palpating the uterine fundus and you're beginning your massage. And you have your client void on the bedpan. And when you go to inspect the lochia, you find that peripad and the chucks underneath it, both saturated with blood. One of the first things you would want to ask your client, when was the last time you changed your peripad? Okay. It might have been 40 minutes ago. Okay. So we still would need to weigh those. Okay. So you're going to get help in there to help you with massaging the fundus and getting some medications. After calling for help, what would you be suspecting if your client was becoming very pale and clammy? What would you think that was going on? So you've got your team there to help you. What are some things that you would see in your client that give you great concern that she's going into hypovolemic shock from the loss of so much blood? Her blood pressure is 100/60. Well, it depends what it was earlier, right? Can't just give you one blood pressure. Let's say it was 138/80 during labor and shortly after labor. Okay, so it's dropped. Her heart rate is 120. She's tachycardia. So which of the rest of these would you see if your client was going into shock? So hypovolemic shock, whether it's postpartum or whether it's multiple motor vehicle accident and somebody has lost a lot of blood, bleeding internally, going into hypovolemic shock, even cardiogenic shock, where what's going on is that the blood pressure has dropped, either from the loss of volume or the loss of a heart rate. The heart rate is so low that the factors in the body that cause compensation, in other words, trying to compensate for low blood volume, hypovolemia, you'll see tachycardia. Okay, tachycardia. Confused, she might be confused because she's lost a lot of blood, not in the brain. Okay, low blood pressure. So what we would see, low blood pressure is a late sign. Okay, it's a late sign. Tachycardia is a late sign. Flushed skin, no, we're not going to see flushed skin. We're going to see pale skin, pallor. No, not tremors or headaches, but confusion and cool, clammy skin. Cool, clammy skin, because all those little blood vessels in the periphery are constricting to conserve blood for the major organs like the heart and the brain. Okay, so peripheral vasoconstriction during shock. Okay, so be on the alert if you're working in critical care for signs of who are those patients that are at risk for shock. Make sure you're monitoring intake and output, watching for bleeding. Do you know how to assess for internal bleeding? Abdominal bleeding, visceral bleeding, going to have a very tender belly. Just like abrupted placenta, the uterus is going to be rigid and it's going to be extremely tender, and she's going to be bleeding massively. So easy to go into shock after that. Okay, good luck on your exam. Make sure you watch all the other instructor videos. And I have my review session, study session for your last exam this Thursday and again next Sunday.